great excitement that I introduce our speaker today, Dr. JoAnn Manson, Professor of Medicine at the Harvard Medical School, Professor in the Department of Epidemiology at the Harvard T. Chan School of Public Health, and the Chief of the Division of Preventive Medicine at the Brigham and Women's Hospital. Dr. Manson completed her undergraduate studies in biology at Harvard, then her medical school at Case Western in Ohio. She then looped back to Boston for her medical training at Harvard and her endocrinology fellowship at University Hospital. She went on to achieve her PhD in public health at Harvard. Her training in the fields of endocrinology and public health and her role as a principal investigator in several large trials and studies has led to her renown as a physician, epidemiologist, and endocrinologist. Dr. Manson is the PI or co-PI of several large-scale research studies, including the Women's Health Initiative Boston site since study inception in 1993. This is the largest study performed in women. She's the PI of the cardiovascular disease component of the Nurses' Health Study since 1999, the dual PI of the large-scale vitamin D and omega-3 trial, VITAL, since 2009, PI of the KEEPS trial, the Boston site, and other trials including the Cosmos and Vivid trial. Her primary research interests include the role of endogenous and exogenous estrogens as determinants of chronic disease, randomized clinical prevention trials of nutritional factors and lifestyle factors related to heart disease, diabetes, and other age-related disorders, and genetic and biomarker predictors of cardiovascular disease and other chronic diseases. She has done extensive research on the health effects of estrogen therapy and of vitamin D supplementation. Dr. Manson is a recipient of numerous awards, including the Women in Science Award from the American Medical Women's Association in 2003, the American Heart Association's Population Research Prize in 2010, the AHA's Distinguished Scientist Award in 2011, the American Heart Association's Research Achievement Award in 2020. She is an elected member of the Association of American Physicians and the Institute of Medicine, the National Academy of Medicine. She is editor-in-chief of Contemporary Clinical Trials, a past president of the North American Menopausal Society, and she has been recognized as one of the most highly cited authors in the world. Most of us remember a time when estrogen and progesterone was prescribed to postmenopausal women as a means of reducing cardiovascular disease. And this was based mostly on observational data. I myself remember being a medical student and watching my attendings advise women to take estrogen and progesterone. The WHI findings published in summer of 2020 shattered this practice after showing that women had increased cardiovascular events and breast cancer events in mostly older women over the age of 60 who had been more than 10 years after menopause. However, the pendulum did start to swing back a little bit after the data was mined and further trials, including the KEEPS trial, which Dr. Manson is a PI of, showed that in younger women who are soon after menopause treated with low doses of estrogen and progesterone, that this can be done safely. She's really informed the practice and management of postmenopausal hormone therapy. We are honored today to have Dr. Manson speak on hormone replacement therapy in postmenopausal women, with timing being everything.
Thank you so much, Maria, for that very kind introduction. It's really wonderful to be here, and it's an honor to have been invited to speak with you about this topic. So first, I want to say no financial conflicts of interest related to this presentation. We just remove. Okay, so I first want to mention that an obscure historical figure once said, things should be as simple as possible, but not any simpler. And I think hormone therapy and health outcomes decision-making about hormone therapy is really a wonderful example of this. The findings have been complex, and they really shouldn't be made any simpler than they are. There are nuances in the findings, and there is no one size answer to using hormone therapy. Not every woman is a good candidate. And so the challenge for clinicians will be to identify the women who are likely to benefit and the women who should avoid hormone therapy, and be able to distinguish between those two groups. And I think the problem we've run into from the very start is trying to see this as a one size fits all issue. But it really shouldn't be made any simpler than it is in reality. And there are nuances in terms of the effects of hormone therapy. Okay, so the goals of this talk will be to review the recent findings from WHI and other randomized trials of menopausal hormone therapy, describe patient characteristics, particularly age, time since menopause, the underlying risk factor status of the woman. I'll even talk a little about biomarker levels, such as lipids and CRP that might help to distinguish, that modify health outcomes on hormone therapy, and also address the role of recent research in improving clinical decision-making for hormonal versus non-hormonal therapy. Now, for those who are interested, we did have a perspective piece about let me see, it was in 2016, so we're now almost 5 years out. But this piece talked about how the clinical care of women, especially perimenopausal, menopausal women, has really been derailed by all of these controversies about hormone therapy. Women are being denied hormone therapy when often they are very, very good candidates. And overall, about 3/4 of peri and postmenopausal women have hot flashes, night sweats. About 20% have moderate to severe symptoms that would make them candidates for pharmacologic treatment of their vasomotor symptoms. And HT hormone therapy is the most effective treatment for vasomotor symptoms. Now, this slide just demonstrates how strong a benefit there is from hormone therapy in terms of the reduction in the number of hot flashes that will occur with almost any dose of estrogen plus progestin. This shows conjugated equine estrogen and medroxyprogesterone acetate, are really all of the formulations of estrogen plus progestin. Even lower doses show very substantial 85% or greater reductions. Now, there is, as you can see, a placebo effect. So it's always really important to have a placebo group in any trial of a medication for vasomotor symptoms, reducing vasomotor symptoms. But you can see a clear difference between the placebo group and this very marked reduction of hot flashes in any of the dose groups. Now, what about non-hormonal medications? Because some women are not candidates for hormone therapy, and they do have significant symptoms. Women with breast cancer, women who have high risk factors like a venous thrombosis, a history of VTE. So it is really wonderful that we can offer women some non-hormonal options as well if they're not candidates or don't have a personal preference to use hormone therapy. And this slide shows some of the options that are available. The only FDA approved non-hormonal prescription medication is the low-dose paroxetine. Here are doses of these medications that can be used, and the reduction in frequency of hot flashes, generally 30 to 50% reduction, which is not bad. Many women will derive an appreciable benefit from these medications, but in general, it's about 1/2 to 2/3 of the reduction that would be seen with hormone therapy. Now, what is really making a difference between the women who will have very safe use of hormone therapy in terms of cardiovascular events and the women who seem to have a precipitated heart attack or even a stroke on hormone therapy? Well, much of this relates to the underlying state and the underlying health of the endothelium. So within the blood vessel, in a recently menopausal woman, usually there is a healthy endothelium. A little few fatty streaks, but generally a woman will not have complicated plaques. And estrogen, when estrogen is given, it will have the effect of increasing nitric oxide synthesis, which will lead to vasodilation in these blood vessels, in the coronary blood vessels. It also will decrease leukocyte adhesion and actually decrease inflammation. The inflammatory state within the blood vessel is decreased in a woman with a healthy endothelium. In a woman who has complicated plaques, already has advanced atherosclerosis, let's say she's 15, 20 years past menopause, has risk factors for heart disease, hypertension, diabetes, and multiple risk factors. This is a woman who is going to have generally a higher risk from hormone therapy and may even have a myocardial infarction precipitated. Because what happens in this situation is the estrogen receptors are relatively non-functional and they're hidden underneath these plaques. There is no vasodilation that occurs. There is no nitric oxide synthesis that's occurring in the blood vessel. Also, there's a stenotic blood vessel, stenotic lumen, and that will put a woman at very high risk of thrombosis and occlusion of the blood vessel when taking especially oral hormone therapy, because we know, and we'll talk a little later, about how the oral estrogen will actually increase synthesis, the liver synthesis of clotting factors. It will go directly to the liver, unlike the transdermal estradiol, which has much less, if any, effect, unless it's given in very high doses in terms of the thrombosis. So you may have occlusion of the blood vessel. And in addition, you have erosion of these plaques, because there is an effect of hormone therapy on MMP, the matrix metalloproteinase, which leads to thinning of the cap of the plaque and often plaque erosion and rupture. So this is a dangerous situation for prescribing hormone therapy. And it's virtually the opposite scenario of a recently menopausal healthy woman who is seeking hormone therapy for relief of hot flashes. Also, women who tend to have the healthier endothelium are also earlier in menopause, and they tend to be more likely to be symptomatic and therefore better candidates for hormone therapy in terms of quality of life issues. So why did we have all these observational studies that suggested that hormone therapy actually, is linked to a lower risk of coronary heart disease, based on more than 40 observational studies in a meta-analysis published like 1995? So we are talking more than a quarter century ago, but there were many meta-analyses, review papers, and individual studies suggesting a lower risk of coronary heart disease among women who were on hormone therapy. Now, keep in mind, these are observational studies, and women are choosing to be on hormone therapy. Clinicians are choosing them to prescribe hormone therapy. So there can be selection factors, and undoubtedly there are some confounding factors that made this look better, this association more favorable than it really was. However, there are some other very important differences between the WHI findings, which did, show overall unfavorable results for cardiovascular disease, and the observational studies. Generally, the age at hormone therapy initiation in the observational studies was 52 years. Very recently menopausal women It was 63 years in WHI. The time since menopause was more than 12 years past menopause. In WHI, only a couple years, 1 to 3 years in the observational studies. So that's a major difference in the clinical characteristics of the women in the observational studies versus the WHI randomized trial. Now, I'm not going to spend a lot of time going through each individual secondary prevention trial of hormone therapy and cardiovascular disease, because I can summarize in one sentence that not a single one of these trials done in high-risk women who already had a history of cardiovascular, a history of MI or stroke or very advanced atherosclerosis and angina, not a single one of these trials showed coronary benefit or stroke benefit. So we don't have to go through them all individually. I think we have a very, very clear answer that, unlike the thinking of 25, 30 years ago, that women at highest risk of cardiovascular disease would have the most to gain from estrogen because estrogen appeared to be so cardioprotective in observational studies. It actually turned out that these were the women who had the most adverse outcomes. And these are clinical scenarios where hormone therapy should be avoided. And it didn't seem to be only oral estrogen, conjugated equine estrogen, or oral estradiol. It also applied to transdermal estradiol and to different formulations of progestogens. So there was really no evidence that these women at very high risk of cardiovascular disease are benefiting from hormone therapy. We have a very clear answer there. So I'm going to focus on primary prevention, the Women's Health Initiative, estrogen plus progestin trial, estrogen alone trial, as well as some of the trials that have been done since WHI. Now, just briefly, I'm sure everyone in the audience knows the overall design of the WHI. It included women postmenopausal. They all had to be postmenopausal, ages 50 to 79. It was stratified by whether or not the women had had a hysterectomy. If they had had hysterectomy, more than 10,000 of them, they were randomized to estrogen alone. It was conjugated equine estrogen at what was then, at the time the WHI was being developed, the protocol in the early 1990s. You know, we're getting to be 30 years later now. This was 0.625 milligrams a day that was used versus placebo. And the women who had an intact uterus, more than 16,000 of them, were randomized to combination therapy with CEE plus medroxyprogesterone acetate, 2.5 milligrams a day given daily. So it was continuous combined therapy versus placebo. Now, as you all know, the WHI, the bombshell findings of the WHI in 2002 led to a sea change in clinical practice. And the trial was actually stopped 3.3 years early because the Data Safety Monitoring Board was getting concerned about the findings, the NHLBI, NIH was getting concerned about the findings. So the trial was stopped after this mean of 5.2 years later. They continued to we all continued to adjudicate endpoints, and it's overall 5.6 years of follow-up. But the earliest findings in 2002, published in JAMA, were based on 5.2 years, and the trial was expected to go 8 years, more than 8 years. Now, what was originally found in the overall study population, this is in the more than 16,000, mean age 63, where there were many women in older age groups. The coronary heart disease risk was increased by 29%. Stroke was increased by 40%. Pulmonary embolism was more than doubled, and breast cancer was increased by 26%. Now you can see that, the risks were clearly outweighing the benefits. And those are a lot of risks from interventions being given for preventive purposes when many of the women were not even symptomatic. It was not really being given for quality of life purposes. It was being given to see if hormone therapy could reduce the risk of chronic disease, as had been suggested by observational studies. On the benefit side of the equation, because this really was the first randomized trial to demonstrate a reduction in clinical hip fracture risk. Other trials of hormone therapy had just shown bone mineral density benefits, but this showed a 1/3 reduction in hip fracture and a similar reduction in colorectal cancer, but this would not outweigh all of these benefits, would not outweigh these risks. Now, 2 years later, the estrogen alone trial was published, again, more than 10,000 women, similarly average age, more than 63. This was a little longer follow-up because it went on longer. Overall, the benefits and risks were more balanced in the estrogen alone trial. However, there was a similar nearly 40% increased risk of stroke, which is what led to the trial being stopped a year early. On the null side, there was no increase in coronary disease, only a modest increase in pulmonary embolism. Breast cancer actually was edging toward being significantly reduced. And this is a finding that is continuing to be explored and mined, and really to try to understand why estrogen alone ended up leading to a significant reduction in breast cancer, whereas estrogen plus progesterone led to a significant increase in breast cancer. Colorectal cancer was not reduced with estrogen alone. Total mortality overall was quite neutral, and the global index, which was a composite of all of these endpoints, was neutral. Hip fracture, again, was reduced here at least as much as with E+P. So that was the benefit side. Now, in 2013, so we're now getting to be 7 or 8 years ago, we published in JAMA very detailed findings for those of you who are interested in seeing all the age stratified and time since menopause stratified findings for a large number of endpoints. And I know you can't see all the details here, but it's really a visual message. This slide shows the comparison of active and solid versus placebo in HASH in different age groups, 50 to 59 in the CEE-MPA trial in the top half, CEE alone trial in the bottom half, ages 60 to 69 in the middle, and 70 to 79 on the right side. Now, the key point here is that the absolute risks are so much lower in these younger women. Whether you're talking about active or placebo group, the results are not even that different in the two groups, as we'll discuss. But the absolute risks of having these events end up being so low that the rate difference becomes very, very minimal. In contrast, when you're talking about women who are 70 to 79 years old, their absolute risks, whether they're in active or placebo, are going to be about 4 to 5 times higher, which means that if you apply the same relative risk of, let's say, a 20% increase or a 30% increase, you're going to have a lot of extra cases of events being caused in these older women. But in addition to absolute risks being greater, I'm going to show you that relative risks also differ in that there were signals that younger women actually had indications for benefit where the older women were showing risks, and we'll go through that. Now, the first one I want to talk about is myocardial infarction, which is the most rigorously adjudicated endpoint that we had for coronary disease, and also all-cause mortality. In the WHI estrogen alone trial, now this is the E alone trial, and I will shortly talk with you about the E+P trial. What you can see when we looked at the results by age group is that the 50 to 59-year-old women had a pretty clear signal for risk reduction that was not that different from what was being seen in observational studies. So the hazard ratio here was 0.55. There was really no appreciable reduction in 60 to 69-year-old women. And for 70 to 79-year-old, there was sort of a signal of increasing risk. The p-value for trend by age, whether this was increasing, these hazard ratios were increasing by age group, was statistically significant at 0.02. Similarly, for all-cause mortality in the estrogen alone group, we had a 30% reduction. It was not quite significant during the intervention phase. We'll come back to this. It was 0.70, no neutral results for the 60 to 69 year age group, and 70 to 79, it was edging up toward an increased risk. And again, there was a trend, a significant trend by age, suggesting the younger women did better than the older women for these outcomes of MI and total mortality. Now, what about estrogen plus progestin and risk of MI and all-cause mortality? We'll also talk about that. So we didn't see much going on with age group. The only group that had a statistically significant increase in the risk of MI was the 70 to 79-year-old women, but there was no p-value for no significant P for trend. However, when we looked at time since menopause onset, and we were able to do this in the E plus P trial, but not in the E alone trial, because a lot of the women in the E alone trial had hysterectomy. We didn't know, they didn't have their ovaries removed. They didn't have, about 50 to 60% did not have their ovaries removed. So it was very difficult to date their actual age at menopause and time since menopause onset. But in the E plus P trial with the intact uterus, we were able to date this. And when we looked in more detail, the women who were less than 10 years since menopause onset had no increased risk of MI. As you got further and further away from early menopause, women had a substantial increase in risk of MI. With 20 or more years since menopause, there was almost a doubling in the risk of MI with estrogen plus progestin. And this was strongly significant P for trend by years since menopause onset. Now, I want to briefly talk about the early versus late intervention trial with estradiol, the ELITE trial design. This is really the only trial that was very specifically designed to test the timing hypothesis. And the WHI was very strongly suggesting that this timing hypothesis, that younger women do better than older women, at least in terms of coronary endpoints, strongly suggestive, but this trial was specifically designed to test the hypothesis, and it included 643 small trials. So it's based on imaging studies and not clinical events. That's an important distinction. WHI is clinical events. It was looking at two different groups that were randomized to estradiol versus placebo. A group more recently menopausal within 6 years of menopause, and a group that was 10 or more years since onset of menopause. They were randomized to oral micronized 17-beta estradiol, 1 milligram a day, and the progesterone was given vaginally as micronized progesterone gel, 12 days of the month, in the women who had a uterus versus placebo. The primary endpoints were the rate of change in carotid intimamedial thickness up to 6 years of follow-up, treatment and follow-up. They also looked at coronary artery calcium, but it did not have much power for that or report those results in great detail. Here are the results of the ELITE trial. So at the top, you see these two somewhat overlapping curves. And this is the women who were at least 10 years past menopause onset. There's really no difference between the progression in carotid intimamedial thickness. They all are progressing. They all have start out much higher level than the younger women. These bottom two curves are the women within 6 years since menopause onset. So there was no significant effect of estradiol treatment. In contrast, among the recently menopausal women within 6 years, the women who were in the placebo group had much greater progression of carotid intimamedial thickness. And the women who were given estradiol had attenuation and really substantial blunting of that increase in thickness of the carotid arteries, and that is a marker for increased risk of cardiovascular events, of coronary and stroke events. So overall, this was a significant difference in the rate of progression, and there was also significant interaction between the older and the younger women. So this provided fairly strong support for the timing hypothesis. Now, I do want to point out that in the KEEPS trial, we did not see a significant difference in the progression of carotid intima-medial thickness. However, in looking very closely and comparing the results of ELITE and KEEPS, it seems that because the KEEPS participants were very, very healthy and they had much lower levels of carotid intima-medial thickness at baseline and less overall progression, it ended up being somewhat underpowered to detect a difference. But I do want to acknowledge that the KEEPS trial did not show those findings. Now, what about other health outcomes? So the hazard ratio, it is important to keep in mind that although we're seeing age differences, a modifying effect of age for coronary heart disease, myocardial infarction, and all-cause mortality, we are not seeing it for stroke, venous thrombosis, pulmonary embolism, breast cancer, and most other outcomes. And that means that the hazard ratios for hormone therapy, if there's a certain increase, like a 30% or 40% increase, it applies across the board. But here's the really key point. There are much lower absolute risks of these adverse events in younger compared to older women. So with hormone therapy, you may, if you're using it in younger women, you may get some of these coronary benefits. You may even see some benefit for all-cause mortality. It takes large samples to actually see that. But if you're looking with oral hormone therapy, you're probably going to get a very small increased risk of venous thrombosis and stroke, but it's very, very small. We're talking 1 to 2 to 3 like extra cases per 10,000 women per year. These are very, very, very low risks in the younger age groups compared to the older age groups. Now here, this actually shows some of the differences. This is in women who are age 50 to 59 in the E+P trial versus the E alone trial. And it's looking at these women per 1,000 women over 5 years. So this is over 5,000 person years. What you see with the E+P in the E+P trial is that there are these small increases in risk for several endpoints, most importantly for venous thrombosis, which is 5 extra cases per 1,000 women over 5 years. It's still a small risk, but you see many endpoints, many health outcomes that are actually reduced by hormone therapy. So it all balances out pretty much to a neutral effect on chronic disease risk, and the women may be deriving a quality of life benefit if they're symptomatic. So on the benefit side, you do see reduction in fractures, reduction in all-cause mortality, reduction in diabetes with E+P. With E alone, the benefit risk profile in the 50 to 59 year age group is even more favorable. You can see that virtually everything here is on the side of benefit. The coronary heart disease, the breast cancer, colorectal cancer, all cancers, all fractures, all-cause mortality, and diabetes. The one endpoint that was slightly increased in the younger women who were assigned to take estrogen alone was deep venous thrombosis. So overall, the message here is that when you're looking at age 50 to 59, the E+P trial does have a more complex balance of benefits and risks. It's a little more adverse than estrogen alone, but the benefits are pretty much equaling the risks. So it's kind of a neutral effect on chronic disease outcomes. And again, if you're relieving hot flashes and improving sleep, that is going to be a net benefit to the women. With estrogen alone, even in terms of chronic disease risk, you are seeing that the 50 to 59 year age group does very, very well with this intervention. Now, what about the absolute risk per 1,000 women over 5 years by age group in the WHI trials? I showed you 50 to 59. Now I want to show you 60 to 69 and 70 to 79. I hope this projects all right, but I'll read you the key points here. In the estrogen plus progesterone trial, for all-cause mortality, you're going to have 5 fewer deaths per 1,000 women over 5 years. In the women who are in older age groups, you're going to have a few extra, but very small. It really do not see increased mortality. And that was one of our key findings. In terms of the global index, which is the composite of everything I've talked about, CHD, stroke, pulmonary embolism, breast cancer, other cancers, hip fracture, and all-cause mortality, you're going to have a little increase in 50 to 59, but you're going to have more than 3 times the increase in the 70 to 79 year age group. So this is 6 extra cases, and it's 19 extra cases in the 70 to 79 year age group. Now, in the estrogen alone trial, again, the 50 to 59 year age group is just doing extremely well. The total mortality, there are 6 fewer cases per 1,000, 6 fewer deaths per 1,000 women over 5 years, compared to 13 extra deaths in the 70 to 79 year age group per 1,000 women over 5 years. For the global index, you have 10 fewer global index cases, adverse events per 1,000 women per 5 years, whereas you have 25 extra adverse events per 1,000 women for 5 years in the 70 to 79 year age group. And in every case, the 60 to 69 year age group is intermediate. So I think it's a pretty clear message that the younger women do better than older women. And we should try to avoid hormone therapy in women at high risk of secondary prevention clinical scenarios, and also women, especially over the age of 70. They just did not do well with hormone therapy. Now let's look a little further at the 50 to 59 year age group in terms of mortality outcomes. For those who are interested, we published this in detail in JAMA in 2017. Looking at all-cause mortality, you can see that 50 to 59, in the overall cohort, it was neutral, pretty much exactly 1. But here you can see that the results, the risk reduction was about 1/3 reduction in both the E+P trial and the E alone trial. When we pooled the 2 trials, because the results were so similar, there was an overall statistically significant 31% reduction in all-cause mortality in the 2 trials. And it was a significant test difference by age group, p-value, p-trend by age. CVD mortality, cancer mortality, other mortality, all were on the side of risk reduction. Here's the 1.0 line, everything in the 50 to 59 year age group in terms of mortality and cause-specific mortality was leaning toward either significant reduction or borderline significant reduction. Now, interestingly, we did see some differences between the women who had bilateral oophorectomy and the women who didn't in the estrogen alone trial, where the results were so favorable. So we published in Annals of Internal Medicine a little over a year ago, in late 2019, we found that if you look at the cumulative follow-up period, and this was over 18 years of follow-up, the women who were 50 to 59 and had bilateral oophorectomy prior to randomization, they did have a statistically significant reduction in all-cause mortality. So they had a hazard ratio was 0.68, and this is where it was on this forest plot. And they had reductions, signals for reduction in coronary mortality, breast cancer mortality, and global mortality related to the global index. If you look at 60 to 69, all-cause mortality was not significantly reduced, and age 70 to 79, all-cause mortality was very neutral. So overall, women with bilateral oophorectomy did extremely well if they were in the 50 to 59 year age group, and they didn't do badly if they were in older age groups, but it's still not really recommended. They didn't overall have benefit. This is mortality. And if you look separately at venous thrombosis, they were still having some venous thrombosis events. So again, we're not recommending in the older women. If you look at women who did not have bilateral oophorectomy, who had ovarian conservation at the time of randomization, they did not have a significant reduction in all-cause mortality. However, virtually everything here was either neutral or on the side of benefit. And they did have, at least in the older age group, there was some indication for a reduction in breast cancer. But again, we're not recommending hormone therapy in this older age group. In the younger age group, overall, the results were quite neutral or favorable. For the global index was quite favorable. In the women who had ovarian conservation, even more favorable in the women who had bilateral oophorectomy. So this slide is ovaries conserved. Now, how can you summarize the results of the WHI? I think it's actually reasonably straightforward. Overall, the estrogen plus progesterone trial did show those risks, as I showed you in that figure. There was increased risk of breast cancer, stroke, pulmonary embolism, decreased colorectal cancer, and hip fracture. CEE, there was a reduction in breast cancer, CEE alone, and a reduction in hip fracture. When you look at the post-intervention phase with the longer term follow-up, we now have, 18 years of follow-up. What we're seeing is this very interesting divergence between E plus P and E alone, that there's an increased risk of breast cancer, and even borderline increased risk of breast cancer mortality with E plus P. Whereas with E alone, we're seeing a significant reduction in both the incidence and mortality from breast cancer. So completely different effects of E plus P and E alone on breast cancer in the WHI. We also saw, I just want to point out, because the first time it's been shown in a large randomized trial, that this combination of estrogen plus progesterone led to a significant reduction in endometrial cancer. It was about a 35% reduction. Now, what about transdermal therapy and low dose regimens? Are there advantages over oral? Well, we do know that there's less effect of transdermal on clotting factors, triglycerides, C-reactive protein, and blood pressure. But unfortunately, there are no large-scale randomized trials that have looked at clinical endpoints the way the WHI has with transdermal estradiol. But we have reasons to believe, based on small studies and biomarkers, that transdermal is less likely to lead to venous thrombosis. And observational studies suggest that. Are lower doses safer? In terms of blood pressure, we didn't see any adverse effect on blood pressure with lower doses of transdermal estradiol, 50 microgram patch that was used in the Climera patch that was used in KEEPS, compared to, we did see a few millimeter mercury increase in systolic blood pressure with the traditional dose of oral CEE or with E plus P in the WHI. In the Nurses' Health Study, an observational study, we saw that the risk of stroke was not increased for women taking the lower dose of conjugated estrogen if they took 0.3 milligrams, but the women taking the 0.625 milligram dose had risks of stroke that were 30 to 40% increased, similar to the risks in the WHI. So dose may be making a difference for stroke. However, the findings are not totally consistent. And for MI, in a Danish national registry, there were no associations found between estrogen dose and MI risk. I do want to caution you about bioidentical hormone compounded, not bioidentical, we have FDA approved bioidentical hormones, which are perfectly fine and actually even some advantages. But it's the compounded hormone therapy. Just some cautions about this. The National Academy of Medicine has recently weighed in to say that, there really are a lot of concerns about dose consistency and safety issues, and that there's really no clear indication to use them, since FDA approved products come in of bioidentical hormones of estradiol, progesterone, micronized progesterone, come in so many different doses. There's really no need to go the compounding hormone route. So I just want to have a few words of caution about that. What about biomarkers? Again, it follows the pattern that the earlier data, the data I showed you follows. That the women who tend to have more favorable profiles, the women who are lower risk, tend to do better with hormone therapy. This slide is a little complex, but it's basically showing that if you start out with a low LDL, you tend to have a benefit in terms of coronary heart disease risk from hormone therapy. If you start out with high LDL, you tend to have an increased risk, and there's a significant interaction between the two. Also, the LDL-HDL ratio is important. If you have a favorable ratio, a low ratio, you do well on hormone therapy. You do poorly if you have a high ratio. Metabolic syndrome, if you don't have it, you won't have an increased risk, or there's less risk of CHD on hormone therapy. If you have metabolic syndrome, at least 3 of these criteria for the definition of metabolic syndrome, then you will have an increased risk on hormone therapy. So it's the general principle that women who are at higher risk tend to have a higher, worse outcomes on hormone therapy if they're at higher risk of cardiovascular disease. It is important to consider a woman's risk of breast cancer.
Hello.
In making decisions. I don't have a lot of time to talk about this, but the NCI as well as the International Breast Cancer Intervention Study have criteria for determining low, intermediate, high risk of breast cancer. There are assessment tools that are online, and generally hormone therapy is fine to use, except when there's a high risk, such as 5%, at least 5% risk over 5 years. And women in this category would generally be women with a strong family history of breast cancer, women who have already had breast biopsy showing atypia, and scenarios like that. We do have a mobile app called Menopro from the North American Menopause Society. I will say that we've had about 100,000 downloads, so a lot of people have this app and it can still be used, but it's no longer available for new downloading, because we're going to be moving to a web-based system that will have even more functionality. But if you do have this app, it is a let's say a very accessible way of looking at cardiovascular risk. It does a CVD risk prediction score, which you can also do online just through the pooled cohort equation. But it does help with decision making. This is the general algorithm. If you're interested in the algorithm we use, it's in the journal Menopause, published in 2014. The algorithm that's used.
Okay, it looks like you had some blood drawn a couple days ago.
Sorry about that. If someone could maybe tell.
TSH was a smidge below range, but really not too bad.
Anyway, so in terms of making a decision about the use of hormone therapy, we're recommending that it be based on symptom management and not based on prevention of chronic disease, because it's so complex using hormone therapy for reduction in chronic disease. But when you're talking about a woman who has moderate to severe hot flashes, night sweats, and is interested in having, it does not have reasons not to be on hormone therapy. She doesn't have contraindications. She has personal, preference or openness to being on hormone therapy. Decisions can be reasonably straightforward based on the years since menopause onset, trying to avoid it if she's more than 10 years Otherwise, she would be a candidate, and also doing an estimate of cardiovascular risk. This can also be done just based on, you can use the available AHA, American College of Cardiology, risk score assessment, the pooled equations, which you can find online. You can also base this on the woman's clinical risk factors. So for example, if she has a prior history of heart disease or stroke, or she has multiple risk factors for cardiovascular disease, and would be otherwise be considered at very high risk, you may want to avoid hormone therapy unless your symptoms are quite severe. But if you do use hormone therapy, consider using transdermal in a moderate or high risk patient, and do really avoid oral hormone therapy in women who have increased cardiovascular risk. If a woman is not a candidate, there are the non-hormonal treatments that we talked about. Decision about duration of use would be based on continued symptoms, patient preference for continuing, and also weighing her baseline risk of breast cancer, cardiovascular disease, and osteoporosis. There will be some women who are at very high risk of osteoporosis, may not tolerate other treatments for osteoporosis, and are symptomatic with the hot flashes, have very low risks of coronary disease or stroke, and there's a lot of room for clinical judgment here. That patient may be a candidate for hormone therapy even at an older age, and maybe a candidate for continued longer term use. Generally, we recommend stopping after 5 years unless the woman is continuing to have symptoms, in which case, you need to go through this benefit risk assessment of whether continuing treatment, the benefits would outweigh the risks. In 2019, we published in JAMA, Jan Schifrin was the first author, if you want to find this, an approach to hormone therapy decision-making, sort of an updated approach. Again, it's based on confirming that there are vasomotor symptoms that are adversely affecting quality of life, affecting sleep, daytime functioning, or quality of life, making sure there aren't contraindications, and then taking into account their age, years since menopause, and their underlying risks of both cardiovascular disease and breast cancer, using risk assessment tools similar to what I showed you. Overall, this algorithm, or this flow chart that we presented in JAMA, would recommend a woman who has moderate to severe symptoms, would recommend discussions of hormone therapy and serious consideration of hormone therapy in women who are age less than 60 years, menopause onset within 10 years, and have lower risk of breast cancer and cardiovascular disease. There's a group sorry, where you would consider it with caution, and then the women where you would avoid it would be those at high risk of breast cancer, cardiovascular disease, or they're more than 60 years old, more than 10 years past menopause, and have moderate, where they have the older age plus at least moderate risk of breast cancer or cardiovascular disease. Just briefly getting back to transdermal, the scenarios where you would want to seriously consider it would be when you are going to be prescribing hormone therapy in the context of obesity or metabolic syndrome, context of obesity, a woman with hypertriglyceridemia, certainly if her blood level is above 400 or 500, you should avoid any oral estrogen. A woman with a higher risk of thrombosis, low libido because of less effect on sex hormone binding globulin. The transdermal will have less effect than oral. I'll talk a little about that. Migraines without aura, a woman could be a candidate, but would consider transdermal estrogen, and gallbladder or liver disease. I want to just briefly mention Hugh Taylor and the KEEPS team did publish on transdermal versus oral estrogen in terms of sexual function using the female sexual function inventory. This was published in JAMA Internal Medicine in 2017. it just suggested better results with transdermal than with oral. And one of the potential reasons for this is that oral will increase the sex hormone binding globulin, and that may lead to a reduction in bioavailable testosterone, and that may have a more adverse effect on sexual function. There wasn't an adverse effect of oral estrogen, it just was that there was a favorable effect, more favorable effect of the transdermal. So that's something to keep in mind. If a woman has sexual dysfunction and there are indications for hormone therapy, I would lean toward using transdermal rather than oral estrogen in that scenario. In conclusion, hormone therapy continues to have an important clinical role in the management of menopausal symptoms. There's still many women who can benefit from hormone therapy. Current evidence does not support the use of hormone therapy for prevention of cardiovascular disease or other chronic diseases. This is really because there are some risks that have been identified. And if a woman is not going to achieve quality of life benefits, then, exposing her to risks such as venous thrombosis, stroke, breast cancer, it really doesn't make sense. Now, I do acknowledge that osteoporosis and fracture prevention is one of those very controversial areas where some women and many clinicians are using it for that purpose, and there's a reasonable case to be made. The best candidates for systemic hormone therapy are recently menopausal and symptomatic women in generally good health who have low absolute risks of these chronic diseases and would derive greater quality of life benefits from treatment. Using this risk stratification approach, looking at age group, looking at time since menopause, evaluating the woman in terms of her age, time since menopause, or underlying risk of heart disease and breast cancer. This is really what's being recommended in terms of decision-making about hormone therapy. And we need additional studies of the different hormone therapy formulations, especially transdermal, doses, routes of delivery, and more research on non-hormonal options. And I'm going to end by thanking all of the participants, investigators, and staff of the WHI, KEEPS trial, ELITE trial, all these research studies. And thank you so much for your attention. And I'll end there. Thank you. I'm going to stop screen sharing.
Dr. Manson, thank you so much for your thorough and lucid presentation. We have several questions from our audience. So we'll start with Dr. Terry Davies. This is excellent talk. Thank you so much. What is your opinion concerning low-dose estrogen in women with a uterus? Is following the endometrial response sufficient?
I generally would not recommend it. However, if you know a patient very well and you really believe that she's going to follow up closely with the endometrial monitoring by ultrasound, transvaginal ultrasound, or whatever assessment, if you're going to be doing an endometrial sampling, I think it's a reasonable approach. However, I don't think that giving micronized progesterone is that dangerous, that if a woman has an intact uterus, I think it's just better to give some progestogen to counteract the estrogen, especially if you're talking about longer term use. But if you're, you're using low dose estrogen, you really, there's some reason you want to avoid a progestogen in that woman, and you believe she's going to be very compliant with follow-up and monitoring, then it's reasonable to do. I would have her sign an informed consent, that she understands the risks, that she understands the importance of close monitoring. And keep in mind, there could be liability issues if she comes in with endometrial cancer years later and she hadn't come in for her monitoring, the monitoring studies. But that is how I would answer the question.
Our second question is from Dr. Emily Gallagher. Thank you for the great talk. Do you have an opinion on giving HRT to BRCA mutation carriers who have no personal history of cancer and have had risk-reducing surgery, including oophorectomy and hysterectomy?
The general view on that is that it's acceptable. There really is no clear evidence that the BRCA positive women are going to have an extra, increase in the risk of breast cancer from hormone therapy. And as long as they understand that, the benefits and risks of hormone therapy, if they're symptomatic, they've had their ovaries removed, they may have quite significant hot flashes and other menopausal symptoms. I think clinicians are going that route. They're not absolutely avoiding. This is a different, scenario. You're talking about a woman who's BRCA positive and has not had breast cancer, correct?
Correct.
Yeah. Okay. So, yeah, I think, and you can find position statements. You can read the North American Menopause Society's position statement from 2017. We're in the process of updating it now, but the recommendation has been that this is a reasonable, very, very reasonable. And there are other guidelines saying that that's reasonable.
A question from our division chief, Andrea Dunaev. Wonderful presentation, JoAnn. Being able to have you speak is a silver lining of the pandemic. Many women do not wish to have menses. What is the minimum number of times per year that withdrawal bleeding needs to be induced with progestin? In hypogonadal women, e.g. Turner syndrome, at what age should estrogen dosing be reduced to postmenopausal dosing? Thanks.
Yeah, well, I'm not a complete expert on this question. It's a very interesting question. My impression is that there really is an inadequate research on endometrial safety with different progestogen regimens. And I'm very concerned about this because I think a lot of regimens are being used, long intervals, lower doses of progestogens, where we really don't know that they're providing the kind of endometrial safety that would be optimal. I will say that, and this is not to make the case that clinicians should be prescribing only combined estrogen plus progestin, but the combination of estrogen plus the CE plus MPA test in the WHI was associated with a significant reduction in endometrial cancer and even endometrial cancer mortality. So that regimen is providing very good endometrial protection. There have been observational studies, these are not randomized trials, suggesting that there's very reasonable protection with other formulation, with sequential, taking the progestogen only 12 days a month or even longer interval, going to 3 months without progestogen, that there is not any significant increase in endometrial cancer. However, it is not showing the same kind of benefit as the combination estrogen plus progestin. So I don't think you need to have a benefit in reducing endometrial cancer. You just don't want to be using a regimen that could increase a woman's risk of endometrial cancer. So in response to that question, I would say that I would like to look much more carefully at that literature, but importantly, I think we need much more research on these questions. And overall, the research suggests that having a shorter not having really long intervals between giving progestogen protection is probably associated with a lower risk of endometrial cancer than having longer intervals. But in an individual patient, the benefits of using a longer interval may outweigh those small risks associated with endometrial cancer.